Ladies and gentlemen, welcome back in 2021. I'm sure you must have had a very good vacations. And with this new year, we are back with our opener batsman, Dr. David Carlock. I'm sure you remember that Dr. David Carlock started this series of webinars earlier, way back in June, and he was opener. And I requested him again on a very important topic, management of malignant biliary obstruction and choice of stents. I'm sure you all know that at times it becomes very difficult to choose the stent, whether we have to put in a plastic stent or a metal stent, and what are the advantages and disadvantages of putting in a particular stent in a given situation. For a difficult topic like this, I requested Dr. David Carlock, who doesn't need any introduction. He's a teacher of the teachers, a mentor of so many of us. We love him. He has been to Pakistan for so many times. He's a patron to Pakistan Society of Gastroenterology, and he has been always kind to accede to our requests. Uh, and it's all yours, Dr. David Carlock, please.
Thank you. Yes. Assalamu alaikum and good morning from New York. It's 8 o'clock in the morning here. It's a very cold, dull day, so it's just the perfect time to talk about this problem. Um, so I'm very honored to start the new year with this topic. And as you say, I started the series, so I feel very much part of this whole series of lectures from various different people. And I'm going to touch on some other aspects of the management of malignant biliary obstruction, which involves EUS. And I know you have a separate talk on this topic, but the two things are so integrated now that I'm going to mention where I think it's important for people to understand where these two things integrate and help each other, because that's really the real world. So this is the topic for discussion this morning. And as you just heard, we are many time visitors to Pakistan. And I think this was the last time in Lahore. So my wife Sarah and I were very happy to visit. And we hope that the pandemic will go away very soon so we can visit again. But we don't know when that will be. So for the younger people listening, and it looks like there are something like 50 or 60 people on this call right now, something changed in the early 90s for most of us in the West, and that was the introduction of the MRCP version of MRI. And it's important to understand that this was a dramatic change for us in the evaluation of the pancreas and biliary tree, because up till that time, diagnostic ERCP was quite commonly performed since the mid-70s. And from the mid-90s, this was no longer necessary for most cases. And you will see during my presentation that MRCP is a very important and now normal part of the evaluation of patients with biliary obstruction. But remember also that CT scanning has also improved enormously. And today, sometimes we actually don't need the MRI to tell us the sort of information that we need at a particular point in that patient's management. And here's just a recent CT scan from one of our cases where you can see very obviously that the bile duct is very much dilated, as are the intrahepatic ducts. So CT scanning in its current form with the detail and improvements that have been made is almost as good as MRCP. So don't feel that if your MRI machine is not capable of producing the lovely images that we expect today, CT scanning may be possible to do that for you, and sometimes both. So what's happened to ERCP, bringing up to the present day, is that we have a whole range of diagnostic and therapeutic procedures that we offer patients. But for today, we're going to focus on strictures, and particularly malignant strictures that we have to manage. Now, management involves both diagnosis and treatment, and I'm going to focus on those two aspects. And as I mentioned, EUS is also an integral part of this evaluation and management, because even today, therapeutic EUS has a very important role to play for the drainage of the biliary tract when ERCP is either not possible or fails. And you'll see what I mean by that in a moment. Now, for those of you who were listening to me last year at the beginning of this series, you saw this slide in the value in the learning and mastery of ERCP, and it particularly applies to malignant biliary obstruction because you have to do all of these things. You need an indication to intervene. You need to access the bile duct, particularly this in this case. You need expertise, of course, in all of the aspects of ERCP. You need to understand the anatomy. I'm going to come back to that in just a few minutes. You need to understand the pathology, which is very important for malignant biliary obstruction because the cancers that occur in this area are somewhat unusual in the way that they spread and affect the bile duct. And then you need a diagnosis. And again, I'll focus on that in a moment. You need to think about complications, which fortunately are less common in patients with malignancy. And we'll come back to that too. Excuse me. Now, when we're thinking about the aims of ERCP and EUS, they go hand in hand, as you see here. The technical and clinical aims are all of these things, but for today, we're really talking about two things: diagnosis and the relief of biliary obstruction. Whether that's in the short term or whether it's long-term palliation, we'll discuss in a moment. And again, you saw this picture a few months ago when we started the series. You have to be able to access the duct of interest, in this case, mostly the bile duct, although sometimes the pancreas also. And of course, what you see here are the use of guide wires. And the technology of guide wires has become so, excuse me, so routine to us, we don't really think about what the guide wires can do. And I'm going to just mention that again in a few minutes. So here's an example of where both ducts are obstructed, the so-called double duct problem. The pancreatic duct is very dilated beyond a stricture, and the bile duct is also dilated. And so you need to, in this case, access both because we sampled both and we drained both. And you can see we put a plastic stent into each duct. So the ability to place a guide wire or two guide wires, and sometimes even more than two, into the duct of interest is very important technical achievement and something that we really need to get very good at in the management of these problems. I'm going to digress to EUS just for a second so you know that what is possible when ERCP is either not possible because of pathology or access or it fails. So EUS allows us to access the intrahepatic biliary tree often from the stomach. I'll show you an example of that in a moment. And you can either do this for a rendezvous procedure to give you access to the papilla, or so that we can insert a stent there, or we can access from above, and we can place the stent through the liver into the bile duct. And that's something that we often do now for difficult cases. We can also place the stent directly into the left intrahepatic system from the stomach and create an hepaticogastrostomy. So there are three options. Or we can go down to the duodenum and access the dilated common bile duct often, and again, provide rendezvous guide wire so that we can pick it up in the checker part of the duodenum and place a stent in the usual way. Or we can place the stent directly into the bile duct through a choledochoduodenostomy created endoscopically, and there are a number of stents that we can use for that too, as you can see there. Or if all else fails, we can access the gallbladder, which is often distended, of course, in these patients, and we can create a cholecystoduodenostomy directly. So again, this I mentioned back in the last year. We have to think about a whole series of accessories available to us. But for today, both for diagnosis and therapy, these are the things that we need to concentrate on: guide wires, various sphincterotomes or catheters, if you prefer, cytology biopsy, direct cholangioscopy. I'm going to mention that in a few minutes, and then of course stents. But for therapy, it really comes down to these things: something to place a guide wire, which for most of us is a sphincterotome today, and the stents that allow us to drain the bile duct. Now, we owe a debt of gratitude to these gentlemen who back in 1960 designed and created, almost by mistake, the material we called nitinol. Nitinol has become such a basic material in nearly everything that we use in endoscopy, certainly in the RCP. Nearly all of the stents that we use today are made of this material, and all of the guide wires that we use have some element of this material in it. You may not know that Nitinol stands for Nickel Titanium Naval Ordnance Laboratory. Why is it called that? Because these two gentlemen worked for the military. They worked for the Navy back in the 1950s and 60s, and they were developing a material to protect ships from attack. Material that would be very flexible, could be made into any shape, would retain its shape, and be very tough to any impact. And they created, as I say, almost by mistake, this material that would change shape under certain circumstances, particularly electrical passage of electrical current through it, and then would go back to the original shape that it was made from and made into. And so it was the first memory metal that was created by these two guys. And we've, of course, used it ever since for many, many different things. But for us today, it's for guide wires and for stents. So let's talk about guide wires for a minute, because it's if your guide wire doesn't work, or you don't have the one that you want to achieve a goal, you're not going to be successful. And it's important to think about guide wires in two ways. You want them to do two very different things. You want them to access something, and then you want it to be stable enough to track something else, usually a stent. And the characteristics of guide wires for these two things are quite different. For access, of course, you need it for cannulation, for accessing a duct, for crossing a stricture, and so on. But for trackability, you want it to maintain access. You want it to be very stable. You want to be able to place something, usually a stent and other devices. And so for access, you want it to be flexible, no friction, make it easy to get where you want to be. But for the trackability, you want exactly the opposite. You want it to be fairly stiff and stable so that it maintains its shape. And even some friction is helpful to pull something into a duct, if you so wish. And we expect a guide wire to do all of those things at the same time. And that's a really tough order. But nevertheless, that's what we've all come to do. Um, when you take a guide wire out of its packet, it doesn't look like very much. It looks like a single piece of material. In fact, that's not true. If you were able to look inside it, you would see that it has many different layers. And as I mentioned just now, nitinol is one of the important components of this. It has many, many characteristics that we like very much. And it's usually coated with something on the outside to give it some strength and resistance to the environment that it's working in. It's also allows it to be a little more slippery than the material that's inside. But the tip is often the important part. I don't know if you can see my cursor here, but the tip is often made of a hydrophilic coating that allows it to be as slippery as we want it to be, because it's the tip that really does all the work when you're accessing, and it's the shaft of the guide wire back here that provides the strength and support for stent placement. Another thing that maybe the trainees haven't really thought about yet, because they just hear these numbers. Unfortunately, we have a non-standardized way of measuring guide wires and other devices. We use thousandths of an inch, millimeters, and a French gauge. It's a sort of crazy system that we've adopted. This is all due to our radiologists who started this whole thing many, many decades ago. The standardized size, we don't quite know why that is, but it became 35 thousandths of an inch, or the 035 guide wire. That's become the standard size. But know what that correlates with in terms of millimeters. It's less than a millimeter, as you see here, 0.89, and it's less than 3 French. Why is that important? It's important because you are using this with a number of other devices, and you have to be sure that this guide wire will fit. I've seen many circumstances where the wrong guide wire was used, or even the right guide wire was used, and then a device that had to be placed could not fit over it because it was too big or too small or too short. And you have to get used to the idea of knowing what size is your guide wire, how long is it, and what it can do. And again, they come in various lengths depending on the circumstances. We can discuss that in the Q&A at the end if you wish. All right, now let's turn to bile duct strictures and how we approach them. And then we'll go on to stents. So I think of a situation like this when you encounter a stricture as what are the rules of engagement? What do you have to think about when you see a patient who you know has a stricture because you've got a nice CT scan or an MRI or even ultrasound, and so you know the stricture is there. So of course you do all the usual things. You take a complete history. I always tell people that if you don't know what this stricture is, think of it malignant. It's malignant until you prove otherwise, because obviously that's something you don't want to miss. And the treatment of a malignancy is very different from the treatment of a benign stricture. As we've already mentioned, use non-invasive imaging first. So it's going to be ultrasound, CT, and MRI. Make an accurate diagnosis. And I've emphasized this here because diagnosis determines everything that you do subsequently. If you don't have an accurate diagnosis, you will not treat that patient appropriately. So very important, and I'll come back to that in a moment. If it's a cancer, you need to stage it because very few cancers, of course, are curable, but that's a whole other discussion. Then plan your therapy and resectability if it is resectable. And remember that you don't want to make it difficult. For the few patients that the surgeon can cure, you do not want to make this more difficult for the surgeon by doing something at this stage that's going to contaminate the area or make it more difficult or put a stent in the wrong place or infect the patient. Those are the things you must avoid. So we do not want to prejudice later management in that situation. So sadly, most of the biliary strictures that we encounter are malignant. In the West, certainly 85% are malignant. It may be even higher in Pakistan, but you can see that sort of cancers that you encounter here, pancreas is still top of the list. Bile duct cancers or cholangiocarcinomas are becoming more common, and I think maybe for you, they're almost as common as pancreatic malignancy, and then the other cancers are less frequent. Just for comparison, and something that you have to keep in mind, the 15% that are benign are a whole range of different pathologies. And it's important to know what these are, but I'm going to show you some examples in a moment because many of them can look just like cancers. And of course, the treatment is very different in those situations. For us, we need a whole team of people to make an accurate diagnosis and manage it. Here are just some examples. So who do we need? I need a team of people with me. These are our 4 advanced therapeutic endoscopists that I work with and have the privilege to do so. These are our radiology colleagues that and laboratory folk that allow us to do all the labs that we take for granted. But MRI and CT are very important. We need technology that we're discussing today. We need pathology and cytology or cytopathology to help us make the diagnosis. And then, of course, we need our surgical colleagues. These are 2 of the pancreatic surgeons that I work with. These are 2 epidermobiliary transplant surgeons that I work with. And then for those patients that need oncology, we have both medical and radiation oncologists to help us. So it's a whole band of people that come together, and we discuss these cases every week to determine what is the best role of management. So let's just concentrate on diagnosis for a moment. Why is it so difficult? Why is it such a problem to make a diagnosis? If you see a stricture in the esophagus or you see a stricture in the colon, we look at it, we biopsy it, and in the main, we get a diagnosis. The bile duct is not like that. Why is it so difficult? So let's look at some of those reasons. So there are many confounding disorders that make it look like cancer that aren't. So if you just look at these 3 examples here, the one on the left is Meritzi syndrome. This is a large gallstone that's compressing the common hepatic duct from the gallbladder. Looks a little bit like a cancer, but isn't. The middle one is a sort of historical interest now. This is AIDS cholangiopathy. We don't really see that anymore since we've had effective therapy for HIV, but this is what it looks like. And then the one on the right is actually a very rare condition. It's a polyp in the bile duct that's benign, but causing obstruction. So you have to be aware of all the different pathologies that can affect the bile duct and may look like cancer, but is not. Why is it difficult? Because of anatomy and access. So just a few comments. These, of course, are mostly benign strictures or occasionally recurrence of a cancer that's been resected. Patients who've had Whipple resection may get benign strictures of the biliary anastomosis to the jejunum, and we've figured out all sorts of ways to get there. I really don't have time, or it's not appropriate to spend a lot of time on this, but just be aware that we do have ways to get to the bilioenteric anastomosis, often using instruments that weren't designed for this purpose, like the colonoscope, for instance. And here's a patient where we've had to do just that. And you can still place the same stents that we use with the RCP, with a standard duodenoscope, but you have to be creative sometimes in order to get them there. Here's another, this is the worst situation where we have to go down through a Roux loop to get to the bile duct. And this is often what you have to encounter and cross to get there. You come across this jejunojejunectomy. This is the Roux anastomosis. And you have to decide, well, which way do I go? The important thing is that to understand is that you need to cross the anastomotic line, this black line that I just, let's put it on there again. And if you don't cross it, then you'll stay on the same side that you're in already, and that's the wrong side. So if you go straight down there, you'll end up in the pelvis. So that's not where you want to be. That one is blind, and this one is the one that you want. So here we've had to use a double balloon enteroscope with a very long Roux limb to get to the bile duct. Here it is. And in the situation, I'll come back to this in a moment, where you cannot get to the papilla because there's cancer occupying the second part of the duodenum, this is where EUS is really extremely helpful to give us access and also allow us to place a stent directly. I'll again return to that. And this is the hepaticojejunostomy, where really nothing else is possible except access from the stomach into the left hepatic duct. Important to make a few comments about the pathology. This is something else that makes life difficult for us. So here are a couple of biliary trees, sorry. We have this sort of concept of the one on the left, that it's a massive tumor around the duct, either compressing it or invading it. But actually, it's not quite like that. Most tumors that arise in the bile duct are much more like this. They spread up and down the bile duct within it, so that there's no real mass effect for us to target with a biopsy or with EUS, FNA or FNB. And the other problem is here, if you look at this pathology specimen, excuse me, you can see that the cancer here has expanded the bile duct size, but if you look at the lumen, it's relatively normal. And so the nature of many of these tumors, particularly most cholangiocarcinomas, is that they're very fibrous and there are very few cells on the surface. So if you use cytology brush as your main diagnostic tool, you're going to fail many times, and that's, of course, that's exactly our experience. It's important that you're familiar with all of the various imaging characteristics of various tumors and non-tumors, as I've shown you. I'm not going to go through these now, but this is something that you really need to gain experience with. It's not just the radiologist telling you what it is. You have to be able to interpret these images as you create them, because often you have to make a management decision as you do though. Sometimes it's difficult to know if it's a stricture or not. Just going to test you on this. So what would you do with a case like this? It looks like the bile duct is dilated. There it is. If you measure it, it's 8 millimeters, right? The gallbladder is still present. The pancreatic duct looks normal. Is this normal or abnormal? What is this? What's your clinical interpretation? Well, if I tell you that the liver enzymes are normal, the patient has no symptoms, and the patient has had previous imaging that looks exactly the same, of course, this is normal. It's at the extreme end of normal. 8 millimeters is probably the upper limit of normal, but this is okay. You don't need to do anything here. Just reassure the patient who's already been told that they have all sorts of problems. How about this one? This is a post-cholecystectomy patient. Here, the bile duct is definitely dilated. It's 12 millimeters. Patient has no symptoms, mildly elevated transaminases, but the patient is very much overweight. What is this? Well, fortunately, we had imaging prior to cholecystectomy that showed exactly the same, because the patient had had stone disease. And this patient has, of course, fatty liver disease, and it's got nothing wrong with the bile duct. This one's a tough one. This wasn't from a patient from another hospital. I was asked to look at these images. If you look at them very carefully, if you look at the MRI, you can see that something strange in the right hepatic duct, seeing both front and back. Something is making that right hepatic duct look abnormal. But the ERCP, in fact, shows nothing. Why is that? Because this is a vascular compression or indentation of the right hepatic duct. It is not pathological, and nothing else needs to be done. However, this one's very different. You can see that that left hepatic duct is dilated, and there's definitely a signal dropout here in the MRI showing that there is a stricture. This turned out to be a cholangiocarcinoma. We have a liver transplant service. So if you're working in a center that has that, you have to get used to seeing an anastomotic stricture that may not look anything like strictures in other situations because the duct above the stricture may not be as dilated as you expect because of the mismatched size of the donor duct or the recipient duct. So again, you have to get used to that idea. One thing that you must all learn, particularly the trainees listening and watching today, are the liver segments, because cancers can occur up in the liver, and often we are stenting and interpreting abnormalities within the intrahepatic ductal system. So you need to know the liver segments, just so you know what they are. On the left side, segment 1, of course, is the caudate lobe. We don't really see that as a ductal structure, but 2, 3, and 4 on the left, if I just run that again, you'll see segment 5 and 8 are anterior, and 6 and 7 are posterior. And they're usually off the same common right hepatic duct, but not always. One of the common variants is the separation of the two subsegments on the right, with 5 and 8 often associated with the cystic duct, as you can see here. And this was a preoperative and intraoperative cholangiography showing the same thing. And just in case you think this is a Western problem, here's a case I did in Ropindi. You can see that there are two right hepatic ducts in this patient who just happened to catch the picture at the time. So it happens everywhere. What about tissue sampling? As I mentioned, if you had a stricture anywhere else in the GI tract, you would just take a look at it and biopsy it. Well, not quite so easy in the bile duct. We do have many ways to image and also sample, but they're not all successful. As I mentioned before, MRI is very helpful to us. It's completely safe and may give you all of the information you need. These are just a series of hilar tumors. I'll return to this in a moment. So you get a lot of detail here from an MRI. It also tells you many things about the extent of the tumor and the ability to resect it, because so few of them are resectable. You want to find the ones that are. So MRI and CT now in 2021 are equivalent in terms of giving you that other information, which I'll happy to answer questions on. So here's a patient with a double duct sign. You can almost see the tumor that I've drawn in here. How do we approach this for diagnosis? Well, if there's a mass like that, then you have a target for EUS, and you can put a needle into it. You can take now a biopsy rather than cytology. We call that FNB. I'm sure you're going to hear much more about that from the EUS lectures. And you have a target. But what if there's no mass? As I mentioned, the bile duct tumors often don't produce much of a mass effect, so there's nothing to target with EUS. Even though you can target the stricture, the mass may not be there for you. So here's a patient with biliary obstruction, but a normal looking pancreas and no mass to target. So that's where we have to focus on the stricture itself. And for decades now, we've been passing cytology brushes over guide wires up into the bile duct with variable success. I tend to use the biggest brush available, which is this one on the bottom right. It gives us the best cytology yield, but as I mentioned just now, we're sort of constrained by the nature of the tumor. If there are very few cells on the surface, you're not going to pick them up with cytology. We are fairly aggressive in using the brush technically, so that we do abrade the surface and release any cells that are there to be captured on the brush. But the nature of the tumor is sometimes difficult. Biopsy is difficult. because we don't really have good biopsy devices for working inside the bile duct. But here's a patient where we placed a guide wire through the stricture. Here we've passed a regular forceps, which we can use with some skill, but you have to be careful. And you can biopsy within the duct, and then of course you have to stent. I'll come back to that in a moment. So what are the successes and failures of cytology and biopsy? The literature is very scattered. You can see the sensitivity of brush cytology is somewhat variable, 30 to 80%. Notice also that the specificity is always high. What does that mean? It means that your cytology pathologist is very careful about what they call positive. They very rarely give you a false positive diagnosis. So their specificity is very high. It's what they say is positive, it usually is. Um, if you take biopsy or FNA or FNB, again, sensitivity is variable, specificity is very good. If you combine them, sometimes you'll get a better answer, and that's often what we do. You can improve on cytology with these somewhat more advanced techniques of fluorescence in situ hybridization or FISH. This improves the diagnosis somewhat. I won't go into that any further. And then what about doing EUS and ERCP sampling at the same time? Difficult to do, prolongs the procedure, but it can be successful. Here are two papers that are recently published, 2019. I put them together because they basically have the same message, that if you do EUS alone, you'll get this sort of accuracy. If you do ERCP alone, you'll get this sort of accuracy. If you combine them, your accuracy goes up to almost 90%. So it is something that you should consider if you have both technologies available at the time. This is perhaps the future. This is from one of my colleagues, one of my past fellows, who now runs the endoscopy unit in Pittsburgh, at the University of Pittsburgh. They're using something called next generation sequencing by looking at cells in a very new way, using an RNA panel. And here, they have a lot of patients with sclerosing cholangitis, and you really want to be sure you pick out the ones that have cancer. So here they have a lot of patients here, 300, almost 350 specimens. And you can see the sensitivity is still less than 80%, although it's better for PSC. So we have this sort of block. We can't really get better than 80% sensitivity for most of the techniques that we use. So as I mentioned, if there was a stricture anywhere else in the GI tract, you would just look at it and biopsy it. So why don't we do that in the bile duct? And this became possible in 2007 with the introduction of the spyglass system, the first optical system, which was very helpful. And we have results from that time, again, showing sensitivity of around 80% and accuracy slightly better. So taking a biopsy directly from something that you're looking at in the bile duct can be helpful. And then this took another step in the right direction a few years ago with the introduction of the electronic version of the same scope. And here, if you look at the data now, this is the digital version. This is digital single operator cholangioscopy. Here's a sequence from the Cleveland Clinic, looking at over 100 patients. And again, you can see now we're getting rather better sensitivity and accuracy overall just by looking. Again, if you think about endoscopy anywhere else, just looking at the stricture can be very helpful. And biopsy was also additional to that. So taking a biopsy under direct vision, of course, is the logical thing to do. And then this is a study from the Orlando group, Rob Hawes's group, comparing malignant and benign strictures, but really try to get at the answer of how many biopsies you need to take, and do you need the pathologist in the room with you? And the answer is not necessarily. If you take enough biopsies and you have good pathology off-site, you get a good answer. So I'm going to show you one example now. I don't know if, hopefully this video is running for you. This is what digital cholangioscopy can look like. This is a patient of mine from a few years ago, had an undiagnosed stricture in the common hepatic duct. It looked a little strange because we saw this material and then we realized that we're seeing sutures from his previous cholecystectomy. And we had really no suspicion that his cholecystectomy was complicated, because nobody told him. But it looked like they had injured the bile duct because there were sutures right there. But we still had to be sure that this wasn't a cholangiocarcinoma. So we not only looked at it, we did confocal endomicroscopy, which I'm going to show you some examples of in a moment. This is what a normal bile duct looks like under confocal endomicroscopy, this reticular pattern of these very fine collagen bundles, which you can see there. So you have a normal pattern on confocal. Now we're taking a direct biopsy, which did not show any cancer. And then we place the stent. So this turned out to be a benign stricture. Uh, Here we're placing a fully covered metallic stent that is removable, and it also treated his stricture. He's done very well in the years since. So confocal endomicroscopy is something I've been interested in for some time. Again, we don't really have time to go into the details of it, but it can distinguish normal, which you see on the left, from cancer, which you see here on the right. And here I am showing one of my past fellows what that looks like. That's been looked at and reported on in the literature, showing us that it can improve the ERCP impression of a stricture by adding the information from the endomicroscopy. And again, this is a number of studies showing that it does improve accuracy, but it's a very expensive technique and you have to have it available to you. Here's another one using volumetric endomicroscopy, different technology. This is here the esophagus where it was first developed, but it can be used in the bile duct also to show us what's beneath the surface. Here are just a couple of cases before we go on to stents, just to show you the sort of things that you have to think about. So here's an unusual case of a 19-year-old female with a stricture, as you can see on the right there in the proximal bile duct. Patient had had this for some time without a diagnosis. That really is unacceptable, but had been stented for almost a year. She was, of course, feeling okay because her bile duct was open, but we didn't know what this was. No history of any previous intervention, and we had no clue what this was. So we did the things that I've just been talking about. We did cholangioscopy, we did cytology, and we did confocal endomicroscopy, which you see here. Not a very good, there you go. And that's in fact normal. We did biopsy it, which showed this rather unusual, almost neoplastic reaction, but this is actually a reaction to the obstruction. And what was the cause of her stricture was a granular cell tumor, which was beneath the surface, and this was resected. Here's a second case, a very bizarre looking lesion at the hilum. Abnormal liver enzymes, ERCP showed this polypoidal mass. And here the endomicroscopy is abnormal, showing these very large collagen bundles, which is typical of malignancy. And here we took a direct biopsy and got these large pieces of tissue, which turned out to be adenocarcinoma. And the third case has two strictures, one in the hilum, one in the distal bile duct, also already suggesting that this could be PSC. Very rare for cancers to appear in two places at the same time. And here the endomicroscopy was normal, and this turned out to be a cholangiocarcinoma. So what is this? So I've shown you many examples, and I'm sure you've seen many examples. What is this? Double duct sign, both ducts obstructed. And I'm showing you this for a reason, because this is autoimmune pancreatitis or cholangiopathy. This is now the great mimic. IgG4 cholangiopathy can look just like a cancer, and you have to be very much aware of that. This is a benign condition and often responds to steroids. So you do not want to resect this unnecessarily. This one, however, now this is difficult. This is one of the problems of interpreting imaging. There's a stricture in here. If you look very carefully, particularly the one on the right, when you rotate the image, this unfortunately is a cholangiocarcinoma. All right, so I've come to the end of the diagnostic part. I'm going to now move on to stents, but this is the algorithm that I've basically taken you through. All of the initial non-invasive imaging history and labs. You find a mass, then you use a US and you sample it by US and you stage it if it's a cancer. If there's no mass, then you'll access the bile duct, you'll sample it the best way you can, and again, you'll treat accordingly. So in two parts here, two places here, you see the word stent, or you see it there during even in the diagnostic part, because in accessing an obstructed duct, you've automatically contaminated it, so you have to provide drainage. And then in the endoscopic therapy part, right at the bottom of this algorithm, you need to provide drainage either long-term or short-term, depending on circumstances. So now let's finish the talk by discussion of stents. I hope now you will certainly know that Stent is actually somebody's name. Charles Robert Stent was actually an English dentist working in the 19th century. Had nothing to do with the stents that we use today, but we use his name for a very good reason. He was a very inventive and uh, innovative guy. Here he is, 1807 to 1885. He developed a method for making dental impressions at a time when that wasn't possible. He made it out of some strange materials, beeswax and plaster of Paris, and then it was used to actually insulate cables because it seemed to have other properties, like it kept out water. It was actually used as the first transatlantic cable coating. Bizarre. And then he added various things to make it different colors, and he made a lot of money out of this and founded his own company. You could buy it by the pound. Remember, this is for dental work. So that was all in the 1800s. And then at the end of the First World War, there was a great need for plastic surgery of soldiers that returned from the war that needed reconstruction. And this guy in Denmark, Dr. Esser, in his book on plastic surgery of the face, used the word stent as a noun, a thing. In other words, for reconstructing skin, in his case, he used a supportive structure, which he called a stent, which was interesting. But the first true stent from our perspective occurred in the 50s, when experimentally these two surgeons were trying to reconstruct bile ducts, and they used a supporting structure, which they also called a stent. And then the famous radiologist, Charles Dotter, used the same word in the vascular system. And then we go on from there in the 70s using the word stent. And then Nipser the great endoscopist who retired not so long ago, started to use the same word for the plastic materials that he made into stents. And then Kees Houbertson, my old friend from Amsterdam, made the first Amsterdam stent, which we still use today from the 80s, and so on and so on. And I'll come to Hans Wallsten in just a moment in the 80s, who changed our world again. So you might be interested to see this. I just did this as an interesting exercise to see how often the word stent appears in the medical literature. And you can see it's not very much in the 50s and 60s, but for this last decade, 80,000 times. It's really very commonly reported on in the literature. So this is one of the questions you've asked me to address: which stent for which situations? There are so many stents to choose from. Which ones do we use for what? So first of all, there are many that you should not think about using for malignant biliary obstruction. Why is that? First of all, the top left are all pancreatic stents, so that's not relevant. But you'll see the ones that I've crossed out mainly have some sort of turn in the tubing. They're usually a pigtail at one end or both ends. They do not drain very well. Compared to a straight stent, we know from early work in the 70s and 80s that flow through a stent which has any sort of curve on it, particularly a pigtail, will reduce the flow. And if that's what you're dependent on to treat your patient, then you're not doing them a good service. So in general, pigtail stents for malignant biliary obstruction, not a good idea. Of course, they have other uses. And we tend to use the straighter stents, either completely straight or slightly curved or angled. Those are the plastic stents that we do have available to us from various different companies, and are the ones that we tend to use. So what's the advantage of plastic stents? Most of them are made of polyethylene or polyurethane. They're relatively cheap. They can be made any length, any size, almost any diameter that will fit down our scopes, and they're readily available. But they have a disadvantage. The disadvantage is that because it's a foreign material, bacteria will adhere to the surface, particularly the inside, and will eventually clog. And so we know this, we expect it. And when we're using plastic stents like this for benign situations, we know that we're going to have to take these out and change them periodically, or we'll know that patients are occluded because they've got cholangitis again and we have to change it. So plastic stents do have many advantages in terms of easy availability and cost, but they have this disadvantage longer term. So many things have been tried to improve the plastic materials and to improve plastic stent patency, but nothing much has really worked. They've been coated with various things and different designs, but nothing much has worked in general. And then, as you'll see in a moment, Hans Wollsten started to look at this whole problem of flow through tubes. And we know that from Poiseuille's law from a long time ago, that the flow, laminar flow, is very much dependent on the fourth power of the radius of the tube. So in other words, if you make the tube just a little bigger, you'll improve the flow tremendously. Now, we are limited by the size of our endoscope channels. So we can't put a huge plastic stent in, but we could put in something that would get bigger afterwards. And that was the concept of a self-expanding stent. And along came Hans Wollsten, a Swedish engineer working in Switzerland. I'm sorry to say I haven't met. He's still working. He's now in his 90s. And in the mid-80s, he developed the whole concept of the self-expanding metallic stent, which you can see many versions of here. And here he is still working. Very creative gentleman. But he invented the self-expanding stent, which of course had his name attached to it, the Wall stent. And that's what we use. Now, if you asked today an engineer to make the ideal stent for all of the things that we use, it would have all of these characteristics, which is absolutely impossible. It cannot do all of those things. So every time we use a stent, it's sort of already a compromise. It's going to do most of the things that you want, but not everything. And today we can stent almost anywhere that we can place a scope. I'll just skip through this since it's not relevant to the discussion, but it's important to understand this. What do stents do? They do a lot of things for us depending on the circumstance. But for today, we're really concentrating on one thing, and that's relieving obstruction. In the future, we may be able to deliver therapy directly, and I'll end with that in a few minutes. So here's a patient with, you've seen this already, but as an example, just both ducts are obstructed. And here's another one. You've seen this already. This duct is obstructed also. So you have to figure out what's obstructed and how do we relieve it. And here's another patient. Both ducts are obstructed, guide wires are placed, and then stents are placed. So how do you choose which stent to place in which patient? Of course, a lot of this is dependent on what's available to you, but I'm showing you here, these are patients having diagnostic sampling, and yet we're stenting them immediately afterwards. That's very important, because as soon as you access an obstructed duct, you have contaminated it, and you need to relieve that obstruction in order to avoid cholangitis. In the short term, those few patients who might be amenable to resection, we need to relieve their obstruction, as I said, because we've just contaminated it, and you may want to drain the bile duct anyway. The surgeon may want you to. Which stents should you use short term? Short term is usually weeks or a few months. We can place plastic or metal, depending what's available to you. What is the evidence that one is better than the other? Well, it's been around for a long time that we know that through randomized controlled trials of metal stents versus plastic stents, that metal do much better. You can see on the left that the plastic stents nearly all occlude within a few months, and metal stents will remain patent for much longer, almost double the length of time. It reduces the number of ERCPs and, of course, reduces the terrible consequence of cholangitis. Interestingly, it doesn't make much difference to the natural history of the disease in terms of survival and overall complications, but the important complication of infection can be avoided to a large extent in the short term by using metal stents. Of course, there's a cost involved, and you probably have access to many more metal stents than we do, since you have access to the stents that are not FDA approved here. which may be a lot cheaper than ours, but certainly as a principle, metal stents perform much better. Do we have evidence that they're useful before surgery? So this is a series of over 200 patients preoperatively drained with pancreatic cancer involving the bile duct. And you can see that the overall complication rate is pretty good, 8%. The survival is not wonderful, but that's the nature of the disease. But it's a safe and effective way to drain the bile duct if you decide that you need to do that. What about using covered versus uncovered metal stents for distal malignant biliary obstruction? This is mostly pancreatic cancer. You can see that the patency advantage for covered is about 60 days extra. The stent survival is about the same. Ingrowth is less, and patient survival is a little longer. This is 50 days, so not a huge advantage, but some. But the disadvantage is the covered stents migrate and move out of position more often than uncovered stents, as you would expect. Nevertheless, the covered stent is favored by most centers now because it's removable and you haven't committed yourself to a permanent stent in patients where you're not sure whether they're resectable or not. So how do you choose? This is an old guideline from really from the 90s, which many of us still think about, even if we tend to use metal stents more here than maybe you do. Metal stents tend to be used for patients you think are going to survive longer. So smaller tumors with a life expectancy beyond 3 months. That's really the message. Plastic stents will occlude within that 3-month period. So a patient who is more advanced disease, metastatic disease particularly, who are not going to go on to chemotherapy, certainly not surgery, those are the ones that might be better to place a plastic stent in those cases. This was actually our own randomized control trial published 10 years ago now, comparing uncovered versus partially covered stents, metal stents, because we thought the partial covering at the ends may allow the stent to be retained. But unfortunately, as you can see, the migration rate was 12% in these stents. So you have to expect that. If you're using a covered stent that is safe and removable, you're going to expect it to migrate. A few comments about hilar tumors before we end. These are the most difficult. You can see in this particular type 2, type 3 hilar tumor requiring drainage of both sides of the liver. You need to access both sides and place, in this case, bilateral plastic stents. And here's a patient with a similar sort of tumor where we can place bilateral metal stents. Now, these have to be uncovered because you cannot put a covered stent at the hilum that block off the contralateral side. And in this case, we've gone through the meshwork of the stent with a special device to place the second stent. This is the so-called stent-in-stent version of bilateral stenting for hilar tumors. There it is. What's important about this is to drain as much of the liver as possible. This is a French study from 10 years ago, but still very much an important message that the more liver you can drain, here more than 50%, the less you will have complications and the more effective drainage will be. I'm going to finish now with the most difficult situations where you cannot get to the papilla. Here's a patient who's got duodenal obstruction and biliary obstruction at the same time. Here we've gone through the side of the duodenal stent to place a stent directly into the bile duct by EUS. And here's a different patient with placing a lumen-opposing metal stent, choledochal duodenostomy. So this combination of the two things is difficult for us, but we have to use all the technologies available to us to drain the bile duct and relieve gastric outlet obstruction. And today, of course, we're also able to place a gastrojejunostomy by EUS and relieve it. So this was a Japanese study published just a couple of years ago, showing that the best option is really to place a stent through the side wall of the previously placed duodenal stent. They tend to last a little longer and be more durable. And as I mentioned right back at the beginning, EUS is our friend here. We don't think about this now. We have it in the room all the time for those patients where we cannot drain the bile duct. ERCP, EUS drainage is both safe and effective. So in conclusion, again, I showed you these conclusions last time, but they apply very much to the cancer patient. The majority of inoperable malignant diseases, number 3 here, can be palliated non-surgically. There's no question that surgery with chemoradiation is the mainstay of cure. It's just very few patients are amenable to this. Um, and multidisciplinary management is essential, and that's the way we handle our patients at our center. So what's happened over the years is that treatment and interventions have become less and less invasive, and we've become part of that whole algorithm of trying to treat our patients. The last thing that I think we'll see develop is the ability to deliver therapy with the stents that we place in the bile duct and the pancreas. We don't really have it yet, although there are experimental versions of these delivering radiation or drug therapy directly to the tumor. I think we're going to see more of that in the future. So I'd like to end by saying you can read all about this in the 3rd edition of our textbook. And I thank you very much for listening.
Thank you, David. Thank you for an excellent talk. There could not have been a better start of the year than this one. In a short span of 1 hour, you've covered almost everything. You've given your lifetime experience in this. I'm sure the audience will be eager to put up lots and lots of questions. Uh, Before other people join in to ask a question, can I ask you one thing? Yeah, you have used the metal stents for such a long period of time. Now, when we are into an era where the chemotherapies are getting more and more effective, what do you think? Metal stents, are they living up to their potential, or do we need to think more? Do we need to think better? Are the plastic better in certain situations? And in the first ERCP, should we opt for when we have a limited data, person is presented with cholangitis and or the person is presented with obstruction, although you've very clearly given a message that 85% of the strictures in the biliary side, they are malignant. It's just the 15%. And if we come across a stricture in the biliary channel, we should be taking it as a malignant unless proven otherwise. So, in your first ERCP, will you like to go with the plastic, or will you like to go with the metal, and especially with the uh, so many chemotherapeutic agents which are mm, making the people live much longer, and the
Right.
kind of complications that we're getting with the metal stents? What do you think?
So, so that's multiple questions in the same sentence, but so I think today, so I'll answer it from what we do, which may not be exactly the same because of cost. I think the first time we see a stricture, and we don't know what it is, obviously we don't have the tissue samples available to us. We may have some information from cholangioscopy if that's what we do the very first time. Remember, we're a referral center, so often we're not the first people to have examined that patient endoscopically. But let's say it's the first time we see the patient, we will tend to place a metal stent because we want, and it's a covered metal stent, we want to place something that's reversible, not permanent. We want something that will provide that patient with biliary drainage for as long as possible without another intervention. If you look at the literature on plastic stents, the literature is always a little bit behind. The number of times people have to re-intervene with another ERCP during that patient's course of treatment, which as you say, will be chemotherapy, is much higher with plastic stents. And that's really something you want to try and avoid. When the patient is in the middle of chemotherapy, everything's getting worse in terms of labs. They're having immunosuppressive problems. You really don't want to scope them again at that point, and you certainly don't want them to get infected. And that's the problem with plastic stents. So if cost was not an issue, I think we would always do metal stent first. And we've tended to do that in recent years because our system can support that. And in fact, it's cost effective because you keep the patient away from us more often. They don't come back to the hospital quite as often with complications. And as long as you use a stent that's not permanent, in other words, it's covered so you can remove it, even though we know that migration rate is a little higher, it's, I think, overall advantageous to do that. So that's what we've tended to do.
Good morning, David. This is
Hi.
Mohammed from
Hi.
Orlando.
Yes, hi. Hi.
Hi. But thank you so much for such a nice lecture and giving us a lifetime really experience and telling us in 1 hour. And I just comment and a question at the same time, especially with regard to Hyler's malignant strictures. We are some people advocate about these metal stents. They look really pretty on X-ray, and it looks really nice to show those in the conferences. But majority of those are 6 millimeter. Obviously, we can put a little bigger too, but the new stent is 6 millimeter. In our experience, and I'm sure in your experience too, with the new like chemotherapeutic agents and whatever treatment available we have, these patients are living much longer than the stent life expectancy. And those are uncovered stents. There's a tissue ingrowth. Majority of these studies have a follow-up of only 1 year or so. So we run into this trouble of these tissue ingrowth, and there may be some solution to that with the RFA, but what is your preference, especially with the Hyler strictures, where you have a life expectancy nowadays more than 1 year? Would you prefer plastic stents with multiple ERCPs or metal stent and then get stuck with that and give those patients obstruction all the time?
Yeah, I think this is the important question that we still have not solved. So you're right to bring it up. Um, Part of this is a technical challenge when you don't know who's doing that first procedure to place multiple stents. We know that draining as much of the liver as possible, as I mentioned, is important. So we try to do that. If we inherit a patient that is already infected, we have to deal with that first. But let's, in the ideal situation, and where we're draining at least both sides of the liver, so 2 stents minimum, sometimes it's more. The question is, what is best? We know that 2 metal stents, 2 uncovered metal stents, work better than 2 plastic stents, even 10 French, the biggest we can. Um, but you quite rightly mentioned that now patients are living a little longer. All stents can potentially become occluded. And the worst problem of all is having 2 uncovered metal stents that are occluded that you cannot deal with. And we obviously we don't want that, and often that still happens. So if you're in a situation where you think that's likely to be, you have to try and predict the future. Obviously, the patient that is got widely metastatic disease or very advanced type 4, you know that their life expectancy is short. So that's really not an issue. It's the ones who you're not sure about, who may last, may live many months, sometimes a year or two. So those we try to put side by side metal stents, because if you put a stent inside the other one, as I showed an example, there's always one side that you cannot access endoscopically. You can always access either percutaneously by radiology or by US. So there's always a possible solution, but it may not be easy. If there's sufficient space in the distal bile duct, which is usually the determining factor, to place side by side stents, that's what we prefer to do, so that you can access them in the future if you have to. It still doesn't solve the problem always of ingrowth and advancing tumor, advancing disease. But you have to try and think ahead, what am I going to do next time when this patient comes back with occluded stents? Can I solve the problem? And you're right, we have not solved that completely yet. But we do think about it, and we try and manufacture, create the situation that's solvable, several months later.
There's a question in the from the participants that when you take a biopsy from the tumor, can you injure the CVD in terms of perforation, and how best to identify the perforation?
Yeah. So it's always possible, of course. But two things. One is the bile duct's remarkably tough. If you think of all the terrible things we do to it when we're doing ERCP, it doesn't perforate that often, does it? The place that perforates is up in the liver. If you can push a guide wire through a small duct up in the liver, that's possible. But the main bile duct is remarkably tough. It's made of, it has a lot of elastin and collagen in it. Um, and when affected by tumor, as I showed you in that pathological specimen, it actually becomes quite thick, 5 millimeters or more, which is really pretty thick. So although theoretically possible, the bile ducts is actually thicker than some of the parts of the GI tract that we also just don't think about not biopsying, like the cecum, for instance. You wouldn't think twice about biopsying something in the cecum. That's pretty thin, and so is the duodenum. So there are lots of situations where we don't correlate what we're doing in the bile duct with other things that we do without thinking. So I think it's fairly tough. However, having said that, I showed you passing standard biopsy forceps up into the bile duct. They're not designed for that. You do have to be careful. You have to develop the skill to do that. I wish we had a really good pair of biopsy forceps that would go without another carrier device. One little trick that I learned a long time ago, also by mistake, if you're placing a 10 French plastic stent and use the 10 French pusher, you can actually put a biopsy forceps through it without the stent. So if you're using the 3-step system that's not pre-assembled, you just have the pusher by itself, you can pass a pair of standard biopsy forceps through the pushing tube and then put the stent in afterwards if that's available to you. That's another little trick. But most of the time, of course, we're biopsying directly through a cholangioscope. So that's not applicable.
So in context to this cholangiscope, when we have the spyglass system available to us, is there any place of confocal laser in the microscopy in the diagnosis still?
I'm interested in it, so I use it. But you're right that you can really get good results now by looking. Just looking, which is something we do all the time everywhere else, and come to a conclusion. Sometimes difficult if the patient's already been stented because the appearances can be very, very much different in a patient who's had a stent there for some time compared to one who hasn't. So just visual inspection of the stricture, we're getting better at that, especially with the images, the digital cholangioscope getting better too. We don't have NBI on the standard cholangioscope. Of course, if you use a small caliber upper scope, which is sometimes possible, you may have NBI, which helps you. But so visual inspection is one step. Adding a biopsy under direct vision and the biopsy forceps for spyglass have also just improved with a slightly better tissue yield. So that's getting better too. So, so your question is, do we get more information from adding confocal to that? I think if you didn't have it, of course, you're still doing pretty well. If you do have it, it does add something extra. We haven't proven that yet since all these other things have improved. But I still use it because we get patients who've already had 1 or 2 ERCPs and don't have a diagnosis. And we want to do everything possible for that patient to make a diagnosis, which is still difficult sometimes. So we use it, but I can understand that as all these other things improve, as well as CT and MR, it may be something that you don't have to spend quite as much money for. But I still
If when
use
you
it.
put in a metal stent, is there any increased risk of cholecystitis or GV, gallbladder mucosa formation?
So I didn't mention it in some of the studies that I quoted just now, but we forget the plastic stents cause cholecystitis too, depending where the tumor is. So it occurs with all stenting procedures, irrespective of the nature of the stent. Um, Comparing uncovered with covered, if you look at all the trials, there's really very little difference. They all have a cholecystitis rate. And we have to be prepared to deal with that. And of course, now we tend to deal with it by EUS drainage. So it always occurs. I wouldn't say there's a huge difference between any of the stent technologies that are available to us. You just have to expect that it will occur in 5-8% of the time.
Professor Ma, are you there? Do you want to say something?
Yes, yes, yes. Hello.
I can't see you.
Oh, can't see you. No, it doesn't matter. But I can see you. So, very happy New Year's,
You
Professor
too.
David. It is very difficult to ask question after your talks because it's such a comprehensive, covering all aspects. I'm just here to applaud your services for Pakistani gastroenterologist training program and the patient care of metabolic diseases. So my gratitude for that, and thank you once again on the forum, and thank you Gyas for asking David to give this wonderful talk. So thank you once again.
Umar, you must
Thanks.
remember that he was our opener batsman for this webinar series, and he's our opener for 2021 as well. So,
Oh
uh,
yes, he is to be opener. He was also the opener of our university programs in last talks because there are 13 university who were on the forum, but obviously that forum for different speakers also. So
and
once again, thankful.
and we
Seems to
must
be.
remember that Sunday it's early in the morning in New York, and it's a new day.
Yeah,
It has been very
D-
kind of him that he spent his
of
time
course.
for.
Dr. Gyas, just a short comment. That's the reason I called him the global mentor. So the title given from our university is a global mentor in GI.
So
Thank
it's
you.
already 15 minutes past 7. It remains for me to thank everyone. It remains for me to thank Dr. David Carlock in particular for sparing his time, and similarly Khalid Hassan and Nadeem Thiami and all others, and all the participants from various parts of the country and various parts of the globe for sparing time, coming on the forum, putting up their valuable questions. Um, and it remains for me to thank the sponsors, Wilson Pharmaceutical, as well, for providing us with the platform. Thank you all. See you next week, and wish you uh, a very happy 2021 and safe from COVID-19.